Hello, my name is Kristen Palan, and I'm currently a third-year PTA to DPT student at the University of Findlay. My research project is a retrospective case report that follows the experience of a patient with Myasthenia gravis who developed knee arthrofibrosis following a septic infection that was a result of a very minor injury to her knee. I initially sought to investigate whether her neurodegenerative autoimmune disease was an inhibitive factor for her recovery and physical therapy. What I discovered is that although it's difficult to know because of limited studies with similar factors, her autoimmune condition may have been more of just a risk factor for developing septic arthritis in the first place, rather than a major contributor to her PT recovery. Although the physical therapist was not involved initially in this case, leading to her diagnosis, the events leading to her diagnosis with her physician revealed essential lessons about the significance of the differential diagnosis during PT evaluations, especially with patients in high-risk groups, such as those with autoimmune disorders. The diagnosis of septic infection in this case was delayed because of the inconspicuous nature of the initial injury, coupled with the patient's lack of understanding about her risks as a myasthenia gravis patient. It was the delay in the diagnosis that may have been a bigger factor in her overall outcomes. PTs who are utilized in a direct access manner will have the opportunity to treat aging patients with both autoimmune and musculoskeletal conditions, and should keep in mind the risk factors that may warrant urgent referral. I'm gonna skip ahead to my case description. Septic joint infection is more likely to occur in elderly patients with weaker immune systems, those with underlying joint diseases like OA or RA, and patients receiving immunosuppressive therapy or glucocorticoids. If a patient fits this description and presents with a 1 to 2 week history of malaise, with or without a fever, erythema, swelling, tenderness, and decreased range of motion of a single joint, they should be examined by a physician to make a rapid diagnosis. The patient in this case underwent an arthroscopic incision and drainage procedure followed by weeks of antibiotic therapy. Once she was finally able to begin physical therapy, her total knee range of motion was 5 to 25 degrees. As you can see on this ICF model, she presented with many structural and functional impairments, as well as numerous activity and participation restrictions. Thankfully, she was retired, she had good health insurance, and several positive personal and environmental factors that strengthened her prognosis. So rehabilitation of knee arthrofibrosis has been claimed to be one of the most complicated orthopedic challenges. It can be exhausting, disappointing, and incredibly frustrating for everyone involved. Here you will see a list of the interventions that were used throughout her almost 6 months of rehabilitation. The home exercise program listed here, this is the initial one, involves stretching and open active range of motion and gentle strengthening, and progressed to more functional closed chain and body weight activities as tolerated. My research led to questions about traditional intense physical therapy with aggressive stretching and manipulation, as had been done in the past with conditions like this. Some of the older reports did support this, but a few new papers suggested that aggressive stretching might not be beneficial in the case of inflammatory arthrofibrosis due to the likelihood of exacerbating and recreating unnecessary inflammation and adhesions. Stretching and strengthening within this patient's pain tolerance appeared to have been the key to achieving the range of motion gains that she did. Due to the severity of the pain involved with knee arthrofibrosis, some complementary techniques that might not be favored decisively in the literature for other conditions, like instrument-assisted soft tissue mobilization, kinesiotaping, and continuous passive motion, did appear to be essential for modulating her pain and enhancing this patient's motivation for continuing her efforts despite slow and frustrating progress. The research that I found did support the use of these modalities for painful arthrofibrosis, particularly in the knee. The outcome measures that were used in this case included the KOOS and the activity-specific balance scale, which was very helpful for the patient, especially with keeping in mind just keeping her continually motivated and showing the small improvements in function that she was gaining, and helping her to achieve and set new goals for herself. And ultimately, she did achieve full knee extension and about 100 degrees of knee flexion. Her greatest accomplishment was achieving full revolutions on her outdoor bike and the ability to ascend and descend stairs normally. Although her functional gains were huge, she was left with some pretty bad joint destruction and constant discomfort that she continues to maintenance with home exercises to this day. My research allowed me to investigate many aspects of this interesting case, more than what I could present here. So I'd be happy to share the full paper with anyone who is interested. Please reach out to me, email with questions, or if you'd like any additional information. This is my contact information. And thank you very much for listening.